I'll be presenting principles of management of surgical site infection. My outline: infection are infections of the tissues, organs, and cavity exposed by surgeons in the course of performing an operation. And just to differentiate colonization from infection, colonization is defined as the presence of multiplying microorganisms on a host, but without any evidence of microorganisms having invaded the host or causing observable disease or damage. Therefore, the microorganisms are present, but they are not causing any disease or symptom. But infection is the invasion and multiplication of a host bodily tissue by disease-causing organisms. Here, the infected individual shows signs that their body is interacting with the microorganism. Surgical site infection was introduced to replace surgical wound infection in 1992 by the Surgical Wound Infection Task Force, and is the leading cause of hospital-acquired infection and may be caused by both endogenous or exogenous microorganism. By definition, it can present within 0 to 30 days post-op or up to 1 year after a procedure that involved the implantation of foreign material such as mesh, vascular graft, or prosthetic joints. So, historic perspective: interestingly, with development of microscope at the beginning of the 19th century and the work of Holmes, Louis Pasteur, Kokas in the origin of infectious disease, the cause of infection was discovered to be caused by microorganisms. And beginning in the 1870s, sterilized gowns, masks, and gloves were gradually introduced following Joseph Lister's work on antisepsis. This initial principle helped in transforming surgery from a dreaded event to a life-saving one. The discovery of antibiotics also in the 20th century revolutionized the field of medicine as a whole, and hope for final elimination of infection was fostered. However, not only have post-operative wounds and hospital-acquired infections continued, but widespread antibiotic therapy has often made prevention and control of surgical infection more difficult. So, surgical importance of this topic: the skin is one of the most important immune organ in the body as it acts as a barrier against microorganisms. Therefore, any breach in the integrity of the skin, as in the case of surgery, predisposes to infection. And surgical site infections, they have like dire consequences, including the prolonged hospital stay. Patients will be placed on long duration of parenteral antibiotic treatment. It increases their health costs, it worsens their mental health and quality of life, and it increases the risk of morbidity and mortality for the patient. Modern surgeons therefore cannot escape the responsibility of dealing with the infection, and in dealing with them, of having the knowledge for the appropriate use of aseptic and antiseptic techniques, proper use of prophylactic and therapeutic antibiotics, and adequate monitoring and support. Surgical site infection accounts for 38% of all infections in surgical patients. Incisional infections are the most common, which accounts for 60 to 80% of all SSIs, and they have better prognosis compared to organ or space-related surgical site infection, which accounts for 93% of surgical site infection-related mortality. The incidence of surgical site infection varies to the heterogeneous nature of microorganisms. So these are just statistics from previous studies. So as a way of classification, we would like to classify surgical wounds according to contamination. Clean wound, and clean wounds are said to be uninfected operative wounds in which there are no signs of inflammation and no cavity, either the respiratory. Surgical wounds according to contamination. Class 1, we have the clean wound, and it's said to be uninfected operative wound in which no inflammation is encountered and no cavity, such as either the respiratory, gastrointestinal, genital, or urinary tract is entered, primarily closed if necessary, and drained with closed drainage. An example of a clean wound is iridectomy because no cavity is being entered. So class 2 involves the clean contaminated wound. Here, the operative wound in which the cavities are being entered, such as the respiratory, gastrointestinal, genital, urinary tract, under controlled condition and without unusual contamination. An example of this wound is cholecystectomy, in which there's no spillage of any biliary fluid. Then class 3 is contaminated wound. Here they are open, fresh, accidental wounds, and in addition, operations with major breaks in sterile techniques. Here, cavities are entered and their incision, acute non-purulent inflammation is encountered. An example of this is appendectomy. Then the class 4 is the dirty wound. These are old traumatic wounds with retained devitalized tissue, and those that involve existing clinical infection or perforated viscous. The definition suggests that the organism causing the post-operative infection were present in the operative field before the operation. An example of this is carrying out a cholecystectomy in a patient with cholecystitis. So the classification of surgical site infection has been categorized by the Center for Disease Control and Prevention based on the depth of involvement of the infection. So majorly, they are divided into incisional surgical site infection and organ or space surgical site infection. The incisional surgical site infection can be superficial or deep, so based on the level of involvement. So the superficial surgical site infection, they are confined to only the skin and the subcutaneous tissue, while the deep incisional surgical site infection involves the deeper soft tissue such as the fascia and muscle layers, while the organ space or surgical site infection, they extend further beyond these anatomic boundaries, and you can see the pictures that are being depicted. So this is just a pictorial representation of the various layers involved: the skin and subcutaneous tissue for the superficial incisional surgical site infection, the facial and muscle layer for the deep incisional surgical site infection, and then the organs. So these are criteria for diagnosing different types of surgical site infection. There's the superficial surgical site infection. Here, to diagnose this, the infection has to occur within 30 days after the surgery, and it involves only the skin and subcutaneous tissue, and the patient must have at least one of the following: drainage of pus from the superficial infection, organism isolated from culture, following an aseptically collected specimen, and then superficial incision that is deliberately opened by a surgeon, and culture or non-culture based testing is not performed, and the minimum of one of the following signs and symptoms: either the patient has pain or tenderness, localized swelling, redness or erythema, or warmth. And then D is diagnosis of superficial incisional surgical site infection by the surgeon or attending physician or any other appointee. But for the deep incisional surgical site infection, the infection occurs within 30 days after the operative procedure if no implant is being used, or if an implant is being used within 90 days. And then it involves the muscle or the fascia layer. Patient must have at least one of the following: purulent discharge from the deep incision, a deep incision, continuous dehiscence of the wound as well, and then culture positive or not cultured when the patient has at least one of the following: fever greater than 38.8 degrees centigrade, localized pain or tenderness. A culture negative finding does not meet this criteria. An abscess or other evidence of infection involving the deep incision, and then diagnosis of the deep incisional surgical site infection by a surgeon or attending physician. But for the organ or space surgical site infection, the infection occurs also within 30 days after the operation, or within 90 days if an implant was used. And then there's involvement deeper than the fascia or muscle layer that is opened or manipulated during the surgery, and patient has at least one of the following: purulent discharge from a drain that is placed into the organ or the space. Organisms are isolated from culture of an aseptically obtained fluid or tissue specimen in the organ, or non-culture based method, an abscess or other evidence of infection involving the organ or space that is found on direct examination. So the etiopathogenesis of surgical site infection, the microbiology of SSI is related to the bacterial flora that is present in the exposed anatomic area of a particular procedure, and it has been relatively fixed during the last 30 years, as shown by the National Nosocomial Infection Surveillance System established by CDC. This study has shown that Staphylococcus aureus remains the most common pathogen for surgical site infection, followed by the coagulase negative Staphylococcus, such as the Staphylococcus epidermidis, the Enterococcus, and then the Escherichia coli. However, for clean, contaminated, and contaminated procedures, E. coli and other enterobacteriaceae are the most common cause of surgical site infection. Also, in recent years, some emerging organisms have become more common, such as vancomycin-resistant Enterococcus and gram-negative bacilli, with their unusual pattern of resistance, have been isolated more frequently. And of particular interest is growing frequency of Candida species as a cause of surgical site infection. Microbial contamination of the surgical site infection is a necessary precursor for one to have surgical site infection, and the risk of this SSI can be conceptualized according to the following relationship between the dose of the bacteria and the virulence of the organism, which is the ability of the organism to cause disease, would increase one's risk of having surgical site infection. And quantitatively, it has been shown that if a surgical site is contaminated with greater than 10 raised to power 5 microorganisms per gram of tissue, the risk of SSI is markedly increased. So these microorganisms, they may contain or produce toxins and other substances that increase their ability to invade a host, and therefore produce damage within the host or survive on the host tissues. For examples are all these gram-negative bacteria that produce endotoxins that will stimulate cytokine production, such as interleukin-1, interleukin-6, interleukin-8, and tumor necrosis factor. These cytokines are also implicated in the symptoms that are seen, particularly with fever, whereby they reset the hypothalamic set point and therefore cause an individual to come down with fever. In turn, these cytokines also they trigger systemic inflammatory response syndrome that sometimes lead to multiple system organ failure. So the risk factors of surgical site infection are often multifactorial, and they include a myriad of factors: the bacterial factor, local wound factor, and then the patient factor. Individual factors cannot alone cause. There has to be an interaction between these three factors is what determines the risk of surgical site infection as a complication in surgery. So as they've been classified, we have those based on microorganisms. So we have remote site infection. So the surgeon is going through a site of infection as his surgical site. So that increases the individual's risk of coming down with an surgical site infection. Also, long-term care facility with prolonged stay in a hospital, patients are at risk of acquiring nosocomial infections. Then the duration of the procedure, the longer the duration of a procedure, higher the risk of an individual coming down with surgical site infection. Like in our theaters now, if a surgical procedure is to last greater than 2 hours, patients are usually given prophylactic antibiotics. Then the wound class, depending on the type of wound class, that's based on contamination. That's class one, clean wound, clean contaminated, contaminated and dirty. Classes, they have their infection rates. Like with clean wound, the infective rate is about 1 to 2%. With clean contaminated wound, the infective rate is about 5 to 10%. With contaminated wound, infective rate is about 15 to 20%. And with dirty wound, the infective rate is about greater than or equal to 40%. Preoperative shaving. Preoperative shaving has been shown to increase the risk of SSI after clean procedures. This practice increases the infective rate about 100% compared to removing the hair by clipper at the time of the procedure and not removing the hair at all, probably secondary to the bacterial growth in the microscopic cut. So therefore, patients should not be shaved before an operation. An extensive removal of the hair is not needed, and any that is done should be performed by electric clippers and should be done just before the surgery. We also have the bacterial number, the virulence, and the antimicrobial resistance. But for local wounds, the type of surgical technique that is done also determines the risk of an individual coming down with surgical site infection. And patients who later have like hematomas, seromas, these can serve as good culture mediums when there's accumulation of blood or serous fluid within a space. They serve as good culture mediums for bacteria to dwell and therefore increase the risk of surgical site infection. Also, the type of sutures that are used, it's been said that multifilament sutures, since they are made up of multiple filaments, if used, they increase the risk of an individual coming down with surgical site infection as the bacteria tend to stay in between the filaments compared to monofilament sutures. Also, drains. Drains are foreign bodies, so they have to be appropriate indication for the use of the drain before a drain is used, because they could also serve as a risk factor for surgical site infection and also foreign bodies. Then for the patient factor, talk about the age. The increasing age would increase the risk of surgical site infection. And patients who have some form of immunosuppression, such as HIV, patients who are undergoing chemotherapy for any form of cancer, patients on steroid therapy, patients with diabetes, patients who are malnourished, all of these factors tend to decrease their immune system and therefore predisposes them to surgical site infection. Also, patients who smoke cigarettes, it increases their risk of surgical site infection. So management of surgical site infection is multidisciplinary, and it will involve history taking, examination, investigation, and treatment modalities. So for history taking, you want to ask the patient for their age. Like we said, an increasing age increases the risk of surgical site infection. The type of surgery that is carried out, either it is an open surgery, laparoscopic surgery. Laparoscopic surgery would reduce the risk compared to open surgeries, and if it's an emergency or elective surgery. So, because with elective surgery, there's better patient preparation, which would help reduce the risk of surgical site infection. Also, intraoperative details, so that the duration of the surgery, use of prophylactic antibiotics, the degree of intraoperative solute, presence of suppuration, and the type of wound closure. The presence of comorbidities, which we've already explained, immunosuppression, diabetes, malignancy, and malnutrition. And then smoking and medications such as chronic steroid use and NSAIDs. So on physical examination, for general physical examination, patient might be acutely ill looking. In cases where patient has already come down with, if it's just a local wound, surgical site infection, patient might just have pain, patient will be in painful distress. However, in cases where the patients have already come down with overwhelming sepsis, they'll be toxic looking, they'll be acutely ill looking. Also, the patient might be cachectic, have altered sensorium, they might be pale because with infection, they can come down anemia and then become pale. They can be icteric, dehydrated, febrile, and they might have significant regional lymphadenopathy. So surgical wound examination may reveal there will be undue surgical site tenderness, there will be erythema, there will be edema and induration, differential warmth, cutaneous crepitous, vesicles and bullae, active wound discharge, which may be copious or not, and then depending on the color, and it might have some odor. It might be wound breakdown surrounding cellulitis. So based on the surgical site examination, there's a grading system. That's the Southampton's grading system, where we have 0, 1, 2, 3, 4, 5. So 0 for normal wound, normal healing. 1 is normal healing with mild bruising or erythema, and then it has ABC, whereby there's some bruising, considerable bruising, and mild erythema. For 2, there's erythema with other signs of inflammation. 2A is at one point, 2B around the sutures, 2C along the wound, and 2D around the wound. And there's 3 and 4. 3 is clear or hemoserous discharge. 4 is pus, and then 5 is deep or severe wound infection. Then, based on the surgical site and where the infection is occurring, if it's following a thoracic surgery, patients might come down with dyspnea. If there's maybe a pus accumulation within the thoracic cavity, patient might come down with dyspnea, patient with tachypneic, there'll be chest wall asymmetry, percussion to the door or stony door, and there's reduced air entry. For the cardiovascular system, if the patient comes down with shock from septic shock, patient will have tachycardia, there might be hypotension. Then for the abdomen, there'll be abdominal distension, which may be generalized or localized. And then they might have the local signs of abdominal wall infection, erythema, persistent tenderness, there's absence of bowel sounds. And then following genital rectal examination, they might have tender, boogie, rectovesical or rectovaginal pouch. So this is just some surgical site infection. This is a child who had a spinal surgery, and we can see that there's some form of abscess or pus along the surgical site. And this is a patient with abdominal. This is the surgical site infection following an abdominal procedure. You can see that there is wound dehiscence and there is sloughs, yellow sloughs on the floor of the wound, and then there is surrounding hyperpigmentation. So this is a skin graft procedure. You can see that due to the infection, the grafts did not take, and there's surrounding erythema. So investigations that can be carried out, we have bone swab or aspirate for MCS. This would help one to isolate the organism. Then for full blood count, there will be leukocytosis, patient might be anemic, and there will be elevation of the differentials, such as particularly neutrophils. So the erythrocyte sedimentation rate and C-reactive protein could also help, and they will be deranged. So blood culture in patients who have overwhelming sepsis, in order to isolate the organism as well. Urine culture as well, in order to isolate the organism. Then we have some radiological investigation that can be done depending on the site of the surgical site infection. So we have plain radiography, chest X-ray can be done for surgical site infection involving the thorax. We have abdominal X-ray, erect supine and left lateral. Abdominal ultrasound scan, also a CT scan or MRI can be done in patients with brain abscesses or thoracic abscess. And then you want to group and cross-match in cases of which patients would need blood transfusion from the anemia. So for treatment modalities, depending on the severity of the infection, the depth of the infection, and systemic involvement, the treatment is usually maybe multidisciplinary. So the treatment approach could be non-operative or operative, involving surgical debridement and re-exploration. So for treatment of incisional surgical site infection, the superficial incisional surgical site infection, that's those involving the skin and the subcutaneous tissue. Most times they do not require hospital admission. Surgeons can just remove the staples or the stitches if there's any suppuration. Then wound edges are expressed for possibility of any wound discharge, and a wound swab can be done in order to isolate an organism. And then the surgical wound is cleaned or irrigated copiously with physiologic saline solution. Then sterile wound dressing change is done daily, and an empirical antibiotics is started before the culture result is out. So inspection of the wound is during dressing for improvement, and then tetanus prophylaxis can be given if the individual is not to date. So IM tetanus tox 0.5 mils start, and then subcute anti-tetanus serum, 1,500 international units start. Then after which, once there's evidence of good wound healing, then a definitive wound closure can be done by secondary wound closure or secondary intention. So for the deep incisional surgical site infection, here also does not require hospital admission if there are no systemic involvement. Here there's removal of alternate staples or stitches initially around the discharging wound site, and care of the infected wound will be done by copious irrigation or by debridement or desloughing, and then application of topical antimicrobial use. For surgical debridement, it involves the use of sharp dissection. It's indicated in the presence of extensive necrotic tissue. So here, start the debridement from the base of the wound and be generous with the debriding tissue. Here, we're just removing the foreign bodies and the dead necrotic tissue in order to aid for better wound healing, because with the presence of foreign bodies and dead necrotic tissues, the wound will not heal properly. Continuously debride until there's presence of red bleeding margin. These are evidence of healthy tissue. Then irrigate the area with normal saline and bactericidal agents. So for wound irrigation, this involves the continuous irrigation of the wound with normal saline is done per dressing as well as after every wound inspection. And all the wound surfaces are irrigated, which may require opening the wound edges and flap for exposure. So irrigation fluids that are opened longer than 24 hours should not be used in wound irrigation. And patients should be positioned in such a way that the solution runs from the upper end of the wound downwards, and it should be done under strict aseptic technique. Clean peri-wound area with normal saline and wipe intact skin with skin protectant wipe. Some cleaning agents that could be used are chlorhexidine, silver sulfadiazine, sodium hypochlorite, hydrogen peroxide. For wound dressing, the wound is packed with saline moist sterile gauze pack. Honey dressing could also be used, as honey has some wound healing properties. Be used for necrotic or deep wound requiring extensive granulation tissue. Then the wound examination is done during dressing, taking note of the wound characteristics. And with good granulation tissue and optimal wound contraction, definitive closure is then planned for. So also not forget to give the patients analgesia, because the under pain, so the adequate pain management is important. So we can use 2% topical lidocaine gel or oral use of systemic analgesic based on the severity of the pain using the WHO pain ladder. So we can either use non-opioids like acetaminophen, that's paracetamol, can use NSAIDs, weak opioids like dihydrocodone, tramadol, or strong opioids like morphine. So for treatment of organ or space infection, most times these patients have some form of overwhelming sepsis and they are toxic. So you want to initially resuscitate them so that they don't come down with septic shock. So you want to site 2 large bulk and cannulas, the patient on IV fluid. The aim is to ensure that the mean arterial pressure is greater than 65 millimeter mercury and the central venous pressure is greater than 12 millimeter mercury. You could also give IV dopamine or noradrenaline are given if the mean arterial pressure is less than 65 millimeter mercury. I also want to characterize the patient in order to monitor their urine output. Intranasal oxygen is given at a rate of 4 to 5 liters per minute, and then blood transfusion can also be done if the PCV is if the PCV is less than 30%. So commencement of IV empirical broad spectrum antibiotics is important. So we can use antibiotics such as ceftriaxone, metronidazole, amoxicillin, clavulanic acid. And definitive antibiotics is then subsequently introduced based on the result of the aspirate MCS. Then the source control of wound infection is required in treating organ infection. This may be achieved via percutaneous image-guided drainage or surgical re-exploration. So abdominal procedures, or in cases where there's an abdominal abscess, for example, a CT-guided catheter drainage is the gold standard treatment for most intra-abdominal abscesses. CT-guided drainage delineates the abscess cavity, and a diagnostic needle aspiration is initially performed to confirm the presence of pus. So a large bore drainage catheter is then subsequently placed in the most dependent position. And after following this, clinical improvement is expected in 48 to 72 hours. The surgical drainage becomes mandatory if the residual fluid cannot be evacuated with catheter irrigation, manipulation, or additional drain placement. So the criteria for removal of a percutaneous catheter is when they are no longer active. So when there's resolution of the sepsis, when there's minimal drainage from the catheter, and when there's radiological evidence of abscess resolution. So complications of surgical site infection, they could have the wound can break down and there will be a burst abdomen in which there's evisceration of the abdominal contents. There can be abscess collection. Patient may have cellulitis or necrotizing fasciitis. There will be pus scars, such as hypertrophic scars. The wound might heal by, there might be keloids or unstable scars. There might be dyschromic scars. Can have chronic ulcers, joint contractures, and then incisional hernia. So preventive measures can be classified according to the three determinants of wound infection and also the timing at which they are implemented, either preoperatively, intraoperatively, or postoperatively. So this table shows the various prevention. So for preoperatively, based on microorganism, you want to shorten their preoperative stay. So we want to shorten their hospital stay in order for them not to acquire some form of nosocomial infection. And there should also be antiseptic showering. They should shower using antiseptics preoperatively. And then for appropriate preoperative hair removal, the patient shouldn't shave their hair before coming for admission for the surgery. However, if any form of hair removal should be done, it should be done in the theater and preferably with the use of a clipper. Surgeons should avoid remote sites of infection. Antimicrobial prophylaxis should be used. Intra-op aseptic techniques should be maintained. Dead spaces, closure of dead spaces should be done enough for to prevent accumulation of hematomas or seroma, which are good cultural mediums for bacteria. And then post-operatively, for local regional challenges in preventing surgical site infection, there might be lack of infrastructures and resources, such as lack of cleaning agents. In cases, they might dilute the hypochlorite, sodium hypochlorite, or they might dilute the chlorhexidine, and which might reduce the effectiveness of these agents. And also the increasing rate of antimicrobial drug resistance, because patients use antibiotics indiscriminately. So in cases whereby there is now an infection, there might be some form of resistance to the antibiotics that's commonly used. So for current trends in surgical site infection, the use of negative pressure dressing therapy has been reported to be associated with faster wound granulation, reepithelialization, and reduction of bacterial load and increased tissue oxidation. They will also have the use of antiseptic impregnated sutures. This would also help in preventing a surgical site infection. In conclusion, surgical site infections, they have their consequences, which we've already mentioned. And despite nearly 2 centuries of progress, surgeons today are still faced with the problems of wound infection after surgery, although the incidence is reduced. So therefore, there's a much need to curtail the incidence of surgical site infection due to its dire consequences. These are my references. Thank you.
Do you know anything about rank and weight field classification of surgical site infections? Make a few comments about pre-operative, intra-operative, and post-operative prevention for surgical site infections.
Can you tell me the practical things that you see on the patient post-op the telltale signs that will suggest surgical site infection, and the things that you would like to do practically on the ward? What do you see on the wound? What are the things, the signs that will suggest surgical site infection?
Definition of sepsis. So the current definition of sepsis, third international consensus or the sepsis theory. Initially, sepsis was defined with respect to the systemic inflammatory response syndrome, but this has been shown to be problematic. So the current definition of sepsis is life-threatening organ dysfunction due to a dysregulated host response to infection, or using the true SOFA, that is the quick sequential organ failure assessment corner, is defined as presence of two or more of these. And the SOFA score, there are three. We have the hypotension, altered mental status, tachycardia. So a patient having two or more of these is said to be septic. That's the latest definition of. The systemic inflammatory response syndrome is a non-specific response of an organism characterized by presence of two or more of the following: one, temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, respiratory rate greater than 20 cycles per minute, or tachycardia, heart rate greater than 90 per minute, or leukocytosis, that is greater than 12,000 cells per millimeter cube, or leukopenia, that is less than 4,000 cells per millimeter cube, or a shift in the neutrophil differential neutrophils to immature bands by greater than 10%. So that's the definition of systemic inflammatory response syndrome. So the initial definition of sepsis was based on that is test plus um, cultured microorganism, but that's no longer the case now. The definition of sepsis has been differentiated from that of sepsis.
When do we say there is infection?
How do you clean an operation site?
Also something called contamination. Contamination is the mere presence of organisms. They are just there, they are not multiplying. Colonization, they started multiplying, but they are not causing a host response. In plastic surgery, we take it to another level. Critical colonization multiply to an extent that they reach a level at which they can impair wound healing, but they don't cause a generalized host response. Classification based on the level of contamination. You have to know that there's a difference between elective appendectomy and acute appendicitis. Elective appendectomy will fall into the clean contaminated, while acute appendicitis, because there's active infection, acute appendicitis is a contaminated wound. So those are our other wounds, the wounds that come in trauma, because they're also contaminated wounds. Because I said contamination is just mere presence of an organism there. We are looking at patients, and all patients are different. You may have a complex patient has comorbidity that is not well controlled. So even if it is superficial, you may need to admit for other things. So if it's in the active phase, some wounds that they're even discharging so much may need to dress 2-3 times a day. So debridement, it could not just only be surgical. You mentioned something about generous debridement. So you should just say you should debride as appropriate. It depends on where you are. There are some places where the tissues are important. You do adequate debridement. It's not always we give IV antibiotics. You give IV antibiotics only when the patient has signs of infection, that's clinically. So sometimes you may just give oral if it is relevant. So everything you do has to be evidence-based.
When you have up to 10 raised to power 5 colony forming units of bacteria on a gram of tissue or a cm cube of blood or CSF, infection has been established.
How to clean our operation site? We use hibitane. We clean twice with hibitane, and then we clean in a circumferential manner, starting from the center and then away from the surgical site. And then after that, when we clean with hibitane the first time, we clean with hibitane again the second time. Then we dry using a dry swab.
We operated a patient that has implants, and you now come to the deep SSI. So what are we doing next?
We want to remove the stitches and then want to irrigate the wound copiously. We also place him on IV antibiotics empirically. We take sample for the for wound swab MCS. Then while the culture result is being awaited, we start him on empirical antibiotics, probably ceftriaxone, because it's broad spectrum.
It's important to know that SSI in the setting of an implant is a disaster for the surgeon, and that's why I see that surgeons such as orthopedic and neurosurgeons go all the way to try and prevent SSI occurring. So in the setting of this, the surgeon might have to face the difficult decision of whether to try prolonged antibiotics use, or depending on the stability of the stability of what the implant was used to, the implant might need to be actually removed. So you can imagine how disastrous that could be. So the spectrum ranging from prolonged antibiotics use, and if there's no response, the implant might actually have to be removed before adequate management of that infection can be done.
So you remove the implants, those implants will still go back in there. So that means you have to wait for the infections because those implants will be discarded.
The cleaning, once you are doing cetrimide, you use spirit. If you are doing povidone, you use povidone all through. You understand? Use spirit. If you are doing hibitane or cetrimide, when you do, you end up with spirit. Then if you are going to use povidone iodine, use povidone iodine all through. Dr. Suleiman.
So who defined surgical site infection?
The Center for Disease Control definition is what we use now.
Yes,
The
excellent.
CDC definition. Okay.
Yes. So surgical site infection, the definition was by the Centers for Disease Control and Prevention. That's the CDC. And it's important whenever we're going through the history of any topic we're presenting, to know the origins, because it will help us to understand the topic better. The percentages, the range in which we see surgical site infections, between 2 to 4% of all patients undergoing inpatient surgical procedures. However, in some other texts, you see a range of between 0.5% to 3% of all patients undergoing surgery. So although it may look like a very small percentage, we know that the implications can be disastrous, bearing in mind that there are various grades, various levels of surgical site infection. And so that comes to, that now leads us to the statement of surgical importance. So why do we, whenever you're going to introduce your topic, it's important to state your statement of surgical importance. We know that, surgical site infections still remains a significant cause of morbidity and mortality, following our surgical procedures. And we also know that the leading cause of readmissions to the hospital, isn't it, following the surgery. And we also know, I'm sure you'd have read in your texts while you were preparing for your presentation, that about 3% of patients who actually contract a surgical site infection can actually die as a consequence of that surgical site infection. So, you can mention all that as your statement of surgical importance, the reason why you are presenting this topic, the reason why, this topic is being discussed, today. And we know that, if you have a surgical site infection as a patient, definitely you stay longer in the hospital, isn't it? So usually patients with surgical site infections have been found out to, stay in the hospital longer than other patients that don't present with surgical site infections. Sometimes as long as 7 days, sometimes even longer than 7 days, up to 10 days or even more. So that is responsible for, that significant morbidity. We also know that although surgical site infections are less common following ambulatory surgery. What is ambulatory surgery?
There are outpatient surgeries like day cases.
Yes. So that's another terminology for day case surgeries. Same day surgery is also another definition. So although we know that, they're less common, surgical site infections are less common during ambulatory surgeries, it can still occur, isn't it? And it can cause significant morbidity. And so we don't just look at it as, okay, fine, it's only our inpatients that develop surgical site infections. We also know that it can occur in our day case surgeries, and so it's important to study this topic. I'm happy you were able to classify it very well, and you had a table that I think you mentioned the risk factors for surgical site infection. You mentioned quite a few things. I'm not sure you mentioned the presence of foreign body as part of the patient factors, in addition to the other factors that you mentioned, like immunosuppression.
Okay.
Did you mention that?
No, it was not part of my patient factor. It was part of the local wound factor.
Okay, local wound factors. Okay, yes, fine. So it's good that you are able to divide it under, the patient factors, the local wound factors. You can also have the procedure-related risk factors, like the formation of hematoma, using foreign materials like drains, Surgeon factors can also be described as procedure-related factors like leaving dead spaces, the history of prior infection, or even, poor skin preparation, poor surgical technique, even hypothermia and contamination from the operating room. We know that our operating rooms are not really ideal. And sometimes, even if you have prolonged perioperative stay in the hospital, you're also at risk as a patient for developing surgical site infection. And so we know that we need to look at our theater environment really well. We need to really plan, and we really need to maintain, our levels of sterility. What is the risk of infection for a clean procedure?
It's about 1 to 2%.
Some texts will tell you 2 to 3%. How about for clean contaminated procedures?
5 to 10%.
Yes, some say 4 to 10%. That's if you use that upper level for the clean procedures of ROI of 3%. So some will say 4 to 10%. How about for contaminated procedures?
15 to 20%.
Yes, some say 15 to 20%. Some will say, okay, between that 10 and 20%. How about for the dirty or infected procedures?
Greater than or equal to 40%.
Yes, it can exceed even up to 40, 50%. Then for prevention, many of these risk factors that we mentioned are not really modifiable, so to speak. Even though the majority of surgical site infections are considered to be preventable. So it's important for us to know how to prevent surgical site infections. And that is why I'm sure you're aware that there has been, among the measures that have been introduced by the WHO, are the global guidelines for the prevention of surgical site infection, first created in 2016, but I think it was modified, I think, in the year 2018 or so. And the objectives of the guidelines, of course, was to help reduce the incidence of surgical site infections. And they had like various recommendations, ranging from very strong guideline recommendations to other maybe less, shall I say, weaker guideline recommendations. So I urge everybody to to check them and make sure that they go through them. It helps us in our practice. And I think in the new global guidelines for the prevention of surgical site infection by the WHO, they actually broadened the guidelines to include guidelines or recommendations from even anesthesiologists, and so it's even more all-encompassing. We also know that our surgical safety checklists are also, also aim to help reduce surgical site infections too, isn't it? And then, of course, I'm happy that you mentioned the post-operative and rehabilitation care. It's also very important in helping reducing the incidence of surgical site infections. You can, for example, in our diabetic patients, glycemic control is very important, not just in the pre-operative period, but also in the post-operative period. So we need to have a tighter blood glucose, monitoring to reduce those complication rates. And we also need to continually educate our patients, on the need for them to come for regular dressings, isn't it? For the need to come for follow-ups at the outpatients clinic, at the regular wound dressings, and the appropriate place to have their wound dressings, and not the way we see some of our patients having their wound dressings at home. I think there's a lot more to be said, but I think let me stop here because I think the time is well spent.